again. But it is my pleasure as director of the Center for Interdisciplinary Trauma Research to welcome Chris today. And this is our first 2025 research colloquia. So really pleased to be able to host Chris, one of our doctoral students and AUT staff members today. So I just wanted to say that the Center for Interdisciplinary Trauma Research considers trauma from a very broad definition of trauma. And from its beginning in 2000, it always is focused on it being interdisciplinary. So it's very much aligned to the new restructure in the faculty. But the idea that it is about all of us working together to address trauma. So just thought I'd share some of the key research projects. Yeah, at least I'll do that. We have been involved with evaluating the violence intervention program in New Zealand Health, Te Whatu Ora, ATIFI, which is the project that Claire Gear is leading, looking at improving the primary care response to people who have been impacted by violence. Now on her second HRC grant, looking at what matters to whānau. We've also looked at some technology. iSafe, which was rebranded My Plan and then went back to iSafe, is a safety decision aid for women who experience abuse. Harmonized was a study strengthening healthy relationships in young people in secondary schools, and other projects that we've done over time as well. So that's just a brief about some of the projects we've been involved with. And just an advertisement, if anybody wants to join us, please just get in touch. Our email contact is on the CITR website. So yeah, thank you very much. So now I'm going to introduce Chris briefly, and he'll do the rest of the introduction. But it's just such a pleasure to have Chris here. And just recognizing that oral health is quite an emerging field in universities. So it is really exciting at AUT to have Chris pursuing his PhD. And already he is a leader in the oral health community nationwide. So just a pleasure to have you, Chris. So I'll hand over to you now.
Thanks, Jane, for the introductions and those kind words. So move it on. Cool. So yeah, thanks everyone. Kia ora again. So my name is Chris, and today it's my honor, delight to be able to present my research and the preliminary finding and the journey that I had over 6 years, and aiming to finish this year sometimes. So the topic is on how can oral health practitioners play their roles in child protections, and these are photos of my lovely supervisory teams. Unfortunately, Sam and Amanda were not able to come. Sam was about to join and then got a call from the clinic saying that he needs to cover for someone else. He's based in Otago. He's a faculty dean of Māori and senior lecturer, but he also looks after the clinic, so he got called in to cover someone. So unfortunately, he was not able to be here, but without support of the supervisory teams, I would not be able to reach and be here today and sharing my findings. So I want to recognize that before I make a start. But yeah, so basically my research question was to understand how oral health practitioners can play our roles in child protection and be the part of the broader interdisciplinary approach and the responses. So it's a bit of introduction. So how I've ended up here. So 2006, I'm born and raised in Korea, the capital city of South Korea, Seoul. I was just a little boy, naughty boy there, did not know how to speak English, but my dad in 2006 literally just decided to pack our stuff and then move to New Zealand. So he made a decision, and I've just landed here 2006 December. It was a lovely day, good summer day, and started to rain over the Christmas. I was very disappointed initially, but I've enjoyed my time. I started my high school. I was just a naughty boy who just could not speak in English. It was an interesting time, so it was a battle to survive, but I've managed there. So in my final year 13, I basically didn't know what to do with my life, just normal boy. Being a typical boy here, I knew I just wanted to do something in health. So I decided to just kind of move away from my family at my own time. So decided to go down to Otago, enjoyed my time there. That's actually when I met my secondary supervisor, Sam, as well, my tutor. So he was a tutor and I was a naughty student. Had some fun interactions there. So I've trained myself to be an oral health therapist. So basically providing dental care to communities and the private practitioners, private communities as well, in terms of their preventative restorative treatments, etc. So I've graduated in 2013, decided to come up back to Auckland, joined the team at the community Te Whatuora. So back then it was Waitamata DHB, and I was based in the South Auckland, Papakura, Pukekoi, Waiuku area, so it was a bit of mixture of high and low socioeconomic areas there. It was fun, and then opportunity came and then joined the team at AUT, so I'm now working in the Department of Oral Health as a senior lecturer, providing the undergraduate teachings and researching for the departments and trying to build the research capacity of the department as well. So that's a brief introduction about me. And I had interactions when I was working for ARTS, Auckland Community Dental Services. I had an interaction with two siblings who came into clinic, had very obvious signs of physical abuse. But back then, I was not competent. I didn't know how to respond to that, which kind of neglected what I've observed. So I've left it, which kind of lingered in my mind for quite a while, and hence I wanted to engage and learn more on the topic. So I've decided to study this. So how can oral health practitioners be more responsive to children's safety and well-being needs? So the journey actually just started from my own reflection of just trying to learn more and want to understand if I encounter another situations, how can I better respond to that? So that's how I've started my master's research projects first. So we all know the right to be protected is very important for our children, to be protected from violence, exploitation, and abuse. And we know the children need to be protected against all forms of discriminations and punishments based on the Convention of the Rights of the Child. But there are also various national and international treaties and guidelines and policies that's emphasizing the needs and the importance of looking after our children who are at needs. Unfortunately, not all of our children is having that safe, nurturing environments where they can basically reach to their fullest capacity in terms of their growth and their dignity and their development. Some unfortunately experiences these abuses, physical, emotional, and sexual abuses, and neglect as well, which includes actual and potential the risk or harm to the children. So it has a very broader term, but anything that can harm a children's can be classified as child abuse and neglect. And I wanted to know how oral health practitioners can play their role in preventing and responding and engaging with child protection services. Just a brief statistics. So there was this cumulative prevalence study done for children born in 1998 to 2015. So 24% of all the children who were born in the period unfortunately had at least one report to child protection agencies by the age of 17.
It's shocking.
It's shocking.
Oh.
And 10% of the entire population were substantiated, they were confirmed as victims of child abuse and neglect by that age of 17. And 3%, so 3 out of 100 children, had to experience an out-of-home placement by the age of 17. So they had to be removed from their family environment to be care of someone else's extended family, or even at the care of Orana Tamariki as well. So these values are very significant and already very concerning. Unfortunately, there's social inequities, and that's very prevalent in our societies and in our community. So the top line basically represents the entire populations, whereas this bottom lines as 42%, 20%, and 7% represent values for our Maori Tamariki and Tai Tamarikis. So there is a significant social inequities there due to all the social impact, colonization impacts, social and structural racism, which plays a huge part to it as well. So yeah, so that's also allowed me to focus more on the way to address, or way to find a way to address that inequities in our societies as well, and the role of our health practitioners in addressing those inequities as well. I'm not going to go too much in details in terms of health consequences, but as we may all know, health consequences of child abuse and neglect is very well known. It's a physical, emotional, psychosocial, developmental, and educational as well. Unfortunately, I don't have my presenter views in front of me, but from my memory, there's a study from New Zealand confirmed that people or our children who experience child abuse and neglect had 13 more likely of not graduating their high schools compared to their non-abused or non-neglected peers. So it's very significant, it's prevalent in our communities, and there's high risk of being a lifetime victimization. So even through their adulthood, they may get violence through their family's domestic situation, etc. And also there are higher risk of them being the perpetrators. So we know this health and other consequences that follows on from this child abuse and neglect. Hence, I've wanted to focus on the prevention and the interdisciplinary supports so we can actually prevent it and do early intervention as soon as we could. So usually around this time, people understand the importance of child abuse and neglect and early interventions, but people usually say, okay, but what's got to do with this oral health practitioners? But interestingly, internationally as well, the role of oral health practitioners in child protection is actually getting recognized and gaining more attention to it as well. And especially in New Zealand, we are quite unique because we got this free dental care for all, for anyone from birth to the 18s. So they are enrolled automatically at their birth, and they get free dental care up to 18. So the services is divided into two major aspects. One is a community oral health services. So that's kind of what we think when you think about community dental clinic. We are based in the schools or community, standing alone clinics. And they look after most of the children up to the school age of 9. So year 9, so that's basically just before high school. And when they reach high school age, they get referred to private dental practitioners, but they continue their care, the free dental care, up to the age of 18. There are some regional differences there as well, but that's usually how it runs. And the care is provided in various dental settings, private cares, communities, schools, sometimes in the hospitals as well, and lots of community engagements and initiatives. So lots of our health practitioners got engagement plans where they go out to sports clubs or community events or school events just to show them and try to get the engagement from children, adolescents, and the families and the communities as well. So we got the unique opportunities to have that regular interactions with children and family, not like some other health practitioners where they may see children and adolescents when they get sick, unless they are very early stage of infants where they get vaccination, etc. When they actually reach some school age, often the time they only go to seek help when they get sick. So oral health practitioners are quite unique in terms of that aspect. which gives the opportunities to build a relationship with children, families, and communities. So, which leads to the opportunities to note some signs and symptoms of child abuse and neglect, so violence, it could be the behavioral clue, or just observing how they interact, how children interact with their families or caregivers, which may give us a hint where they may need some support. It could be early signs of parents or caregivers struggling, providing the care, then we can link them to the support network where they can provide the safe and nurturing environments. And these are some list of orofacial manifestations that I've just searched in the literatures. And these are usually quite severe forms of oral manifestations. But as I mentioned before, oral health practitioners can observe the interactions and the behavioral clues, how children interact with their families or caregivers, which may provide the broader picture of things as well. Which basically leads to my first phase of the research. So this was done as part of the master's research project. So when I started my master's, my intention was just to learn more initially. So I had no intention to expand this to a doctoral project. I was just like, okay, I think master's project will be quite a manageable size where I'll be able to learn more, engage more, learn about research kind of things. So that's basically what I've done as part on this phase one. So it was part of my master's research, which aimed to address the question of how are oral practitioners doing in child protection. So at this stage, my main goal was to understand our responses or how well we're doing as a professions. So in terms of study, I've conducted a descriptive exploratory cross-sectional study engaging with using anonymous online survey tools, and the participants were dental therapists and oral health therapists only. So if I just give a brief background of those two professions, so in terms of oral health professional workforces, we've got specialists, we've got dentists, but we've also oral health therapists, which myself is basically we used to have age restrictions to 18, so we were able to provide restorative cares and basic fillings and extractions for baby teeth, etc., up to age of 18, and all the periodontal care gum treatments for adults, elderly patients, etc. But in 2 years ago, that age limitations got lifted up, so we basically can provide the restorative treatments, fillings, and that kind of things to entire age range now. So that's oral health therapists. Dental therapists got same scopes in terms of restorative treatments, but they do not provide a gum treatment. So we don't do any surgical interventions like open flap surgeries or cutting it open, do like wisdom teeth extraction. There's a surgical scope which dentists and dentist specialists provide, but dental therapists and oral health therapists focuses on more the preventions and restorations, etc. Yeah. So at that time, my focus were on dental therapists and oral health therapists because the two professions were the profession who provided the care to children and adolescents mainly, and most of them worked in the community settings back then. Now it's scoping out a little bit more, but they used to be the biggest workforce in the community. So my focus were on those two professions when I conducted the research. In terms of research findings, this was more the quantitative analysis of the survey. So 97% of all the participants identified child abuse and neglect as important social issues. I forgot to mention that the participant rate was by 11% of the entire profession. So I was able to send the survey out to all dental therapists and oral health therapists who are registered under the council, and roughly 11% participated in the survey. And out of them, 97% identified as an important issue. Only 74% reported that they can recognize the signs and symptoms of child abuse and neglect, which basically gone down to 48% reporting that they are familiar with the reporting process. We can already see the decrease in the digression of that confidence level from 74 to 48 with the familiarity with the supporting process. And on some further states, 74% of participants identified one or more suspected cases during their careers, but only 21% took follow-up actions. So we can already see the 50% gap where practitioners identified some suspected cases, but did not follow up, did not provide any supports, which basically just got left out of the systems. And common barriers to ACT were these are fear of false reporting, fear of further violence towards a child, lack of knowledge to detect and report potential cases, and limited confidence in child protection services. So especially the lack of knowledge to detect and report, especially the reporting part, requires significant barriers, and the further violence towards a child was another one. When I was conducting this part of the research as master's research, even for myself, my view was quite narrow, and my view was very focused on the detection and the reporting side of responses. So my initial understanding of the role of practitioner was to detect and report, and I thought that was the end of it. But as I basically realizing or conducting this research, I realized that there is actually more roles that oral health practitioner can play. So, which led me to think what can actually be done to promote this and increase awareness of this, and to help oral health practitioners to be more responsive to those concerns, and then providing that safe, supportive environments to children and their families. So at this stage, that was the time that I got my PhD teams together, and then I got the reporting, the research proposal done. It was just after COVID time as well, so that was very interesting. All the meetings got cancelled by the universities. They said, oh, okay, the university faculty team will meet in 3 months. So it was quite an interesting process back then. That's how I started my PhD and how I've led to my PhD research. And one of the first things that I had to do, or that I've engaged, was I've tried myself to improve my knowledge. I wanted to know what can we, as a profession, we can do to provide or be the part of the broader support network. So this is how I've initially drafted and of my understanding of role of oral health practitioners. So at that point, I've summarized into these 4 tiles: identifying oral facial manifestation and behavioral clues, supporting children and their families and preventing maltreatment, engaging in early referrals and reporting, and collaborating with an integrated team of diverse discipline. So these were one of the this was basically outcome of initial literature searching that I've done to understand or broaden my understanding of role of oral health practitioners. And at the same time, I've engaged with lots of training, lots of workshops or learning opportunities, webinar conference, and even field work as well. So Jane helped me to have a wonderful opportunities to be able to visit Te Puroho. So as a part of Starship Hospital, integrated team of responses in child protections. So I had a field work 2 weeks there, just observing how they do. I would basically went in there 8 o'clock in the morning, just stay till 5, 6 o'clock in the evening, and then just observing what happens in that environment. So it gave me the broad understanding of what actually happens if severe cases or severe child abuse and neglect cases get referred to the system, which was very eye-opening opportunities as well. So through all those learnings, I basically got my proposal done. I've adopted, it's a mouthful, explanatory sequential mixed method design. So I've used the first phase 1 quantitative research as part of the bigger mixed method design, which I've used it as phase 1, and then subsequently added a few more phases to basically broaden the understanding of the role of oral health practitioners. So before I go too far from my understanding of the initial oral health practitioners, their roles, I wanted to understand what are some of the successful strategies that's used internationally to support oral health practitioners, because there's nothing in New Zealand, there's no local data, and there's no local research ever conducted before. Before me, there was only one publication, one cross-sectional studies. So I wanted to basically understand some of the international strategies that's offered that's been tested, implemented and tested. So for that aspect, I've conducted a scoping review, which screened 787 records and included 20 studies. And key strategies basically came out from there. So first was practical guidelines to support interdisciplinary child protection responses. So internationally, there were very detailed or comprehensive guidelines that support interdisciplinary approaches and inviting dental practitioners into the bigger, broader interdisciplinary child protection responses. So that was very prevalent, as they were common in various countries. And having the dental-specific educational program as part of university curricula or in-service training opportunities were used very readily as well. In New Zealand, there's various child protections or family violence training programs, but there's no dental-specific program. But internationally, because dental practitioner works in that unique environment or different settings, or often in the community and often in that very isolated dental building. So the dental specific education programs were used readily to support oral health practitioners to be more responsive to their concerns. And lastly, there were attempts or initiatives to help oral health practitioners to understand their legal and professional obligations. So there are lots of guidelines or literatures or practical like infographics, etc., which aim to help oral health practitioners to understand their local legal and professional obligations. So those were identified as a key findings from the scoping reviews, which actually led to the third phase of the research. So phase 3 aimed to understand the professional and legal responsibilities of oral health practitioners in New Zealand, basically. And they also got informed by lots of interactions that I had with oral health practitioners in general. And also came up at the survey finding as well, that the associated fear of oral health practitioners when they engage with this child protection agency, or just the notion of child protection or child abuse and neglect. And lots of organization guidelines or organization policies recommended but kind of forced oral health practitioners to contact their caregivers or inform their caregivers if they're going to use that, if they're going to make a referral to other services or on tamariki or anything, which is got its own purpose to it as well. But if someone's working in a very rural and remote area by themselves, there are lots of experiences from oral health practitioners relating to their safety concerns and things like that. So in this phase, I wanted to understand the actual professional and legal responsibilities or requirements for oral health practitioners practicing in New Zealand. So for this part of the study, I've reviewed legal documents and professional guidelines that governs or that's relevant to oral health practitioners practicing in New Zealand. And these were basically documents or legal constitutes that were included there. So 4 New Zealand statutes, 2 regulations, 3 government department guidelines, 1 dental regulatory authority scope of practice documents, a dental council documents, and 1 professional association policy statements were included in the review. And from that, those legal documents and the professional documents were helped to basically document the legal and professional requirements in terms of their roles in child protections. So those documents basically or legal requirements did not impose a legal duty to report to suspected child abuse and neglect, but at the same time, it also established the mandatory principles that children's welfare and the best interest are the paramount consideration of all of our actions. So the little brackets that I've wrote that next to it is basically the legal statutes. So OT is Orang Tamariki Act and FB is the Family Violence Act. And also advocated for early interventions where possible. So Orang Tamariki Act Section 18 specified that early intervention should be paramount and should be advocated for every opportunities. And in terms of their reporting and information sharing rights or duties, it clearly specified that oral health practitioners or any health practitioners can disclose the information for child protection purposes. And look, there are multiple practical guidelines, government guidelines to support health practitioners in their responses or information sharings. So there are about 3 guidelines that were relevant to oral health practitioners, which can guide them when to use it and to help them to decide whether they can disclose certain information to others or not. And to address the concerns that oral health practitioners had in terms of the safety concerns, the Section 66K of Orang Tamariki Act encouraged to consult with children and caregiver when disclosing. So that's basically that aspect were included in lots of organization policy documents, asking them to consult with children and caregivers when they're going to use or refer them to other protections agency. But it also specifies that it's only if it is practicable and appropriate to do so as well. So I can't remember the actual literature because I don't have my thing here, but I've actually documented at the publication that I had. If it is not practicable and safe to disclose and have the consultation with the families and the caregivers or communities, then the practitioner should not put themselves at risk of getting repercussions and things like that as well, because that happened a lot in the dental environments, especially people working in the communities or schools or by themselves. Often they stay later, they stay behind, and usually after school hours as well, because they finish at 5 o'clock where school staff leave at 3:30. Then they might be the only personnel on the ground seeing patients. So there are some incidents where parents basically came up to the clinic and then argued for these reasons. So basically, it specifically says that if it is practicable and appropriate to do so as well. So from the understanding, from findings from phase 2 and 3, I was able to kind of refine my understanding of the role of oral health practitioners in child protection and their care. So that included prevent child abuse and neglect, support children and their families, guide families to adequately support, take interdisciplinary approach, prioritize early detection and intervention, and refer to child protection agencies if required. So I think I'm still in the journey of refining all of this my understanding, but I've understood, I was able to gain the insight that the importance of early detections and interventions and providing that interdisciplinary, the wraparound supports, because oral health practitioners, we are the experts, the teeth, the gum, and drills, and probably doing some extractions and etc., giving oral health promotions, but we may need someone else with different sets of knowledge or expert knowledge to help and support the families and children. But we got the unique positioning in terms of the engagements and having the opportunities to build a relationship. So I was able to basically focus more on that aspects with my research later on. So it's basically those understanding helped me to with my last phase of the research, which was a qualitative aspect, qualitative research to understand how oral health practitioners be supported in their practices and making some recommendations to practitioners, organizations, councils, etc., to be more responsive and to help oral health practitioners to be responsive to child protection cares. So study information, there was a qualitative study. So focus groups and semi-structured interviews were used both. My initial intention was to have focus group sessions to engage or observe their interaction and how they basically form their social ideas or interactions or shared ideas from their experiences. But due to a busy life as well and the COVID impact still, because we as a dental professionals, we are still playing catch up from COVID pandemic. So we are not up to the previous levels, pre-COVID levels yet. So everyone had very busy schedules. So I had to use a bit of both. So focus groups, I had two groups. So one with 6 participants and another one with 4 participants. And the rest of them were basically conducted through semi-structured interview. And there were 3 participant groups, a total of 21 participants. So group A was oral health therapists and dental therapists. B was dentists and dental specialists who is working in the community and the hospitals and providing the regular care to children and adolescents. And the third was Te Whatuora dental service managers. So different Te Whatuora, different areas got their own dental service managers. So those regional managers were included or recruited as part of this research project. And I've used reflexive thematic analysis from Brown Clark. The main decision was that because myself is an oral health practitioner and my experiences and my subjectivities, I knew that it will play a place game during the analysis and data collections and etc. And I wanted to use the subjectivity and reflexivity as a tool and as my strength in data analysis. So I've selected reflexive thematic analysis for this part of research. And so it generated themes. So there are 4 themes with 2 sub-themes for the last one. So there was opportunities to build relationships, culture, and systemic awareness of oral health practitioners, collaborative approach to child protection, and building safe and supportive environments. So for the first one, as I've explained, as I've already mentioned, so unique positioning to engage with children and the family and having the regular interaction were identified as a great strength for oral health practitioners in child protection responses. There's some limited capacity due to the high dental needs, still catching up with all the COVID time and due to recent funding cuts, etc. The limited capacity were identified as some of the barriers or deficits that they're experiencing, and further challenges in the rural and remote areas, because in one area, I can't remember exactly, but one area who looks after 70,000 children, we only got 1 practitioner who's looking after the whole area at the moment. So there's quite a bit of challenges in those rural and remote areas. Yet oral health practitioners are doing their best to use these opportunities to their advantages in terms of their child protection responses. They know they might be the only person for that family in terms of their interaction with the health practitioner as a health practitioners. So they are trying their best to use this unique positionings to help with this child protection responses and linking them to the supports that the family needs. So this was one of the quotes from participants. People within the community would make those approaches to us because it makes whānaus more comfortable to actually ask for help and be able to talk to us to get help that they need. So just emphasizing that relationship opportunities to build their relationship with families and the communities. Second theme, so culture and systemic awareness of our health practitioners. Participants were able to recognize the complex nature of child abuse and neglect, and the internal and all the external factors, all the influences, the social factors that plays into influencing the child abuse and neglect and leading to some of the neglect and abusive behaviors. So systemic barriers and inequitable health and social outcome and health literacies and all of those were identified or recognized by our health practitioners, and ensuring and participants recognize the importance of understanding the social and systemic barriers that may have led to the behavior. So not stereotyping or not just labeling someone as child abuse or child neglect, but being mindful of that and having that awareness of cultural impact and systematic impacts there as well. Cool. And of course, everyone's on their journey, so participants recognize some of them were at the start of their journey, some a bit more advanced than some other people, got more knowledge or more awareness. So the participants recognize the different stages of their journeys, but reinforce the importance journeying together to cultural safety or providing the culturally safe care, not just for child protections, just for their oral health provisions as well. So one participant said, I do find that Maori people are often misunderstood. So this is a Maori Pacifica clinician, which is a barrier for them not wanting to come into services because of the vibe that you get in. It's an attitude that you get in. So, and then this participant reinforced the importance of journeying together and developing their cultural awareness. And the other participants said you got to be quite respectful and mindful of those things, all those things that influences or may have contributed to the family situations or the family environments. Collaborative approaches to child protection. So participants recognize the very importance and significance of collaborating within the dental team, so among the dental team, but also with other experts from diverse disciplines, and they showed appreciation towards those collaborators, the Oranga Tamariki people, public health nurses, social workers who are based in the school and the community. They have a very appreciative of amount of supports that they can access through their channel because they are the experts in child protections, so they appreciated that collaborations. Of course, some also had a degree of reluctance there due to some negative experience that they may had through past experiences, or just having that negative social connotations towards certain agencies as well, uplifting issues, etc. So some are a bit reluctant, but in general, they are very appreciative to the collaborative efforts that they're engaging and how it can also improve later on as well. They recognize the limited resources or inefficient organization process, which further challenged the effective collaborations, having so many documents to fill out if they want to just contact Oranga Tamariki people, or the amount of phone call they have to inform before they are able to actually get anything to the school, etc. So there are some organizations, limitations around that collaborations. And this was quite interesting one. The oral health practitioners were hoping to get more reciprocity or constructive relationship with them, not just them being the person who just report to them and then leaving everything to them to do all the actions. There is some view of that as well, but many participants actually wanted the reciprocity as well because they can also help having those unique positionings, and also just getting some feedbacks once it get refers to the other agencies as well, because they'll need to see the same families again in 6 months' times and 12 months' times, but they usually don't get any feedbacks from other agencies as what has happened or what kind of support has been implemented. So they just get a bit scared in some ways of seeing the families again. So having the constructive relationship are identified as a key important aspect of it. I loved this quote. It says, "It takes a village to raise a child. I'm so strong in collaborative practice because we all have different strengths. Although I think I might have certain qualities that are my strength, I've got to find someone else with those that aren't my strength." So I think that summarized this theme really well there. And the last theme was the building safe and supportive environments, which also had two sub-themes there. But with the bigger theme, as I've already mentioned, we introduced the safety concern around the physical and mental health of oral health practitioners as well. So not knowing what has happened, or just having their mental, like just emotional kind of stress posts, observing some of the things they may have encountered in the clinical environment. So safety concerns around that. And the participants called for resources and supports to provide the safe care to children and family, which are basically divided into those two sub-themes. So personally, to have to ring up a family of a child who I think is being neglected, I wouldn't. I just wouldn't, because that's putting yourself so much at risk. So that basically shows some of the safety concerns participants has expressed during the focus group session, actually. So first sub-theme was simple guidelines on identification and responses. Initially, I had comprehensive guideline, but for all the requirements, we thought it needs to be simple, not comprehensive, because if it's too comprehensive, it's going to get too long. So this is not what we are aiming for. We need some practical, very simple guidelines to help our health practitioners to identify and respond to their concerns. So focusing on identification, responses, and preventions, and a way to help or facilitate the collaborative approaches. But at the same time, avoiding being overly prescriptive, because we know different family situations, different factors plays into effect in every cases of the child abuse and neglect or earlier stages of that. And participants strongly called for action from dental council, because as a regulator, they've actually got just one line saying that it's our responsibility, but there's nothing that supports what we have to do. So there's a strong call for action from dental council as a regulatory body. Second sub-theme was to build a safe and supportive environment. The second sub-theme was to active promotion of workforce development in child protections. Participants recognized the limited undergraduate curricula and in-service professional development opportunities in child protections in general. Even myself, I've actually gone through all my previous lectures, and I had 40-minute lectures for child abuse and neglect, family violence, and everything all together. So it's because it's listed as our competency in our documents, they had to deliver a lecture, and that was basically what I had as an undergraduate student. So having the regular and relevant education, so not teaching about the hospital responses when someone's working in the community. So actually making it relevant to the daily practices. And it was very interesting. I found this part quite interesting. Participants actually want to build their confidence. They want to actually normalize this talk around child protections and its prevention, because the term child protection or child abuse and neglect is scary. They are scary terms, and they believe these terms or responses or any discussion related to these must be normalized. So having that opportunity is just to talk about what they've experienced, what they've observed, or training they've attended, or any opportunities for them to normalize this, where they can basically bounce idea each other, and form that ally together. Yeah, so keeping it at the forefront of our mind and making less scary. Yeah. So moving forward, basically, I thought I kind of summarized into a couple of recommendations. I'm still working on this aspect, so I'm at my writing up stage of my discussion parts. So I've got some drafts, still got drafts, so they have not finalized yet. So partnership efforts to create the practical guidelines and the policy documents, and also partnership efforts to create educational programs for undergraduate curricula and in-service professional developments, and also exploring views of children and the caregivers as well, because that was also actually a part of my initial doctoral plan, but yeah, we decided due to lots of barriers and lots of challenges that has happened through this PhD journey, we've decided to just leave that aspect for now, and I may engage it after PhD project, trying to explore the views of children and caregivers, and trying to understand what they actually want from oral health practitioners on sites, in the community, in the private clinics, etc. So yeah, so I thought that kind of represents where we are. So there's a bigger puzzle. It's not easy, probably like 22,000 more pieces of puzzles in there, but oral health practitioner can be the missing puzzle there, trying to put all together and giving that support to the family and the community. So yeah, they can basically reach to their fullest development capacity and being and happy children, basically. Yeah, so we're all here to work together. So yeah, so because I feel like oral health practitioner is a very early stage of this journey, and as a profession as well. So it'd be good if this collaborative practices and the partnership can be formed to basically help our children and the families in the communities. So that's what I had, and all of the recommended acknowledgements from different associations and Te Whatuora as well, and of course the participants of this project and supervisory teams there as well. That's it.